My name's Mamas. I'm Professor of Cardiology at Keele University. I graduated from Oxford University. During my time at Oxford, I went there in 1991. I did basic science for 3 years, then took 3 years out of my studies to do a PhD in Oxford, so looking at basic ion channel function, particularly potassium channel function, and then went back and finished my clinical training in the year 2000. Thereafter, I trained in general medicine like we do in the UK, so I trained in general medicine for a few years, and then started my cardiology training at Manchester.
Interventional cardiology? Or?
No, general cardiology.
General.
So in the UK, we do general cardiology for maybe 4 or 5 years, and then do interventional cardiology. So I did general cardiology where we do everything, pacemakers, echo, electrophysiology, all the exciting things, and then moved into interventional cardiology. Did interventional cardiology for a couple of years, and then became a consultant, so an attending in the US, as they say. I did 3 years in Manchester as a consultant, independent operator, and then I was offered the professorship at Keele University in 2015, and so moved over there.
What do you think about this meeting? And do we need conferences nowadays?
Yeah, so I think this meeting is very useful. I mean, as you know, there's been a move in the whole world really towards radial access, and the reason why there has been this move towards radial access is because we know that major bleeding complications during the PCI are associated with an increase in the risk of mortality. We know that about half of all major bleeding complications are from the access site, and so that's why many people have transitioned from femoral to radial, and that's what we've done in the UK. So in the early 2000s, radial procedures were 5%, 10% maybe. Now, 95% of all PCI in the UK is radial. The problem is that the patients that have most to benefit from the radial approach are often the most complex patients. And they're often the patients that need the most complex procedures. And so the very complex patients are often the elderly, female patients, and they have very small radial arteries. But of course, to do the very complex procedures, you need very big sheaths. So you need 7 French, 8 French to do complex CTOs.
We have rate spasm or something else, yeah?
Yeah. And so that's really why then I would say the Japanese have been the drivers of trying to miniaturize equipment, number one, and change the approach so that we can do these complex procedures through the radial approach. And so they've done that in a number of ways. Number one, they've really pushed the development of sheathless guides. And sheathless guides are useful. Why? Because they reduce the size of the hole that you make in the radial artery by 1 to 2 French. And the second thing is that they've miniaturized the equipment that you can use through these systems. So, for example, in Europe, North America, the angioplasty wires that we use are 0.014. In Japan, it's 0.010.
Yeah.
So that you can then use, for example, 2 balloons down a 5 French guide. And so if you imagine, you can do things like kissing balloons in a sheathless 5 French guide, which is the same as a 3 French introducer sheath. So you can immediately see that, we've really miniaturized things. I think the third thing that the Japanese have taught us is when you do things well. So they're really the ones that have pushed imaging in coronary intervention. I think imaging is very useful. It's useful in planning your procedure, in deciding, how to prepare your lesion, adequate sizing, and then when you've positioned your stent, deployed your stent, making sure it's optimal. So making sure your stent's expanded, making sure there's no issues like an edge dissection, that you haven't landed your stent in areas of high plaque burden where we know that there's an increased risk of stent failure down the line. So I think, because of all these reasons, I think that these sorts of meetings are really useful. I guess your second question, do we still need meetings?
Yes.
I mean, we've all come through the COVID pandemic, and we've all, joined Zoom
Digital
meetings.
conferences.
Yeah.
And now.
The problem is, I don't know, what you think. I'd like to hear your thoughts as well. But for me, when I have to go to, say, do a digital meeting, I'll save 20 minutes, 30 minutes for my talk,
Yeah.
and then I do something else in clinic. I'll see a patient, I'll do a case, and so I don't really have time then to learn from the meeting. I do my talk and then go away. I guess in these sorts of meetings, in live meetings, I think there very much is a role for them, because you're moved away from your hospital setting, so you're forced to go and you actually learn a lot. So, for example, in this meeting, I've seen a lot of new technologies that's given me ideas. Your talk, for example, the John talk, being able to puncture the radial artery, passing 2 sets of catheters to a single radial. That's given me some ideas. Maybe it's something that I might try back in the UK. The new Asahi sheathless system, where you can peel the device again. I've not seen that before. When I saw it, I texted one of my friends saying, we need to get this in the hospital. So I think, it's great. And also meetings, it's not just what you learn in the meeting, but it's who you meet. It's the deals that you make, the discussions, the scientific exchange, the collaborations.
This is the main point.
And I think you can't get that on Zoom meetings. And, my interest, I'm an academic. I have a lot of interest around using routine data and trying to work out outcomes of patients with PCI that aren't entered into randomized trials. So, for example, one of my big interests is patients with cancer and how we treat them in PCI, what their outcomes are.
Which cancer?
All cancers. So different cancers. And we've done a lot of work on that. But again, it's often, going to meetings, talking to people, getting access to new data, access to new ideas when you talk to people. That's how science progresses. And so, for me, it's a welcome change to come back to meetings rather than do things on Zoom.
Yeah, I agree with it. Thank you. Yeah. You told me earlier that you had visited Russia and named St. Petersburg.
Yes.
Around 25 years ago.
Yes.
Tell me please about this experience.
Yes, so this was at a time when I was doing a PhD. So I was doing a PhD in the Department of Pharmacology at Oxford, and I was part of the British Physiological Society at that stage. And in those years, there was an exchange program between the British Physiological Society and the Russian Physiological Society. So, as a student, I was a PhD student, I went over to St. Petersburg. It was the first time I had gone to the country. And it was great again to have exchange with many of the Russian physiologists at the time. From a cultural perspective, I mean, you have the Hermitage Museum, one of what I would say the world's best museum. I spent a day there, and I felt that perhaps I only saw, a fifth of what was there. You could probably spend a week there. And also, getting to understand the culture, the city, experienced Russian food. And it was quite interesting because at the time, it was, when many people in Russia didn't speak English. And so it was very difficult. I could speak German. I learned German at school. So I was finding that I was communicating a lot more in German. And sometimes it was quite interesting. So you'd go to a restaurant and people wouldn't speak English. There'd be no English menus. And so literally you would have to, try to, guess, with hand signs. And then sometimes I would just order things without knowing what I'm ordering. So I would just point to the menu and, have a surprise. And, it was good memories. And I think, it was a nice exchange. And I think that's the thing, having the opportunity to go to many meetings all over the world, you get exposed not only to different physicians, different ways of doing things in different countries, but importantly, to culture. And I think that's really important from both the medical and the human perspective, that you get to experience different cultures for people. And yeah, I mean, it was great memories. And more recently, I visited Moscow in 2019. So this was a visit at a digital cardiology meeting. I used to be part of the European Society of Cardiology, e-cardiology working group. And so it was a joint meeting. And again, it was a very interesting meeting. We discussed various aspects of e-cardiology. One of the things that we focused around, or I focused around, was the utilization of big data and how it can impact on our practice. And another talk that I discussed at the time was around social media and the use of social media in cardiology. And of course, a lot of the education happens in social media. I mean, I met you guys on Twitter, so one of the social media platforms.
What kind of social media do you prefer?
So I'm only on one platform. I use Twitter. I think Twitter is very good. There's a big community of cardiologists there where we discuss cases, we discuss research.
Some cases,
research. So often, what the way I would say is that if you go to a lecture, you have your lectures from 9 o'clock till 10 o'clock, 11 o'clock, and you have to go to those lectures. Whereas something like Twitter is asynchronous education. And what I mean by that is 24/7. So you're not restricted to, you can only go to this lecture at this time of day. It's there, information flow is there, and it's there all the time. And you can dip in, dip out, you can find topics that are interesting, you can have discussions. And you can have discussions with people across the world. So I have discussions, people from the US to Japan to Saudi Arabia to Russia, Australia, everywhere, all over the world. And so it really helps in the globalization of education and the globalization of discussions in our speciality. So again, it was a great visit, and again, I learned a lot around using big data, machine learning, and so forth. So it was a mixture of engineers, mathematicians, computer scientists, cardiologists at this meeting.
How you got involved in TCT-MD, and what is your current position there? So I have worked. One of the things that I really enjoy is communicating science to people and discussing science with other people that are interested in science. And so before I worked in TCT-MD, I used to work for Medscape, so Medscape Cardiology, and I used to be the Medscape UK cardiologist. And in those days, I used to do videos very much like we're doing today, where I would go to meetings and discuss all the late-breaking clinical trials. TCT-MD is a great news resource, and I've been a great fan of it for many years, even before I became involved in it. So again, what they have is that they have a number of journalists, so 4 or 5 journalists, and they report stories, so either things that are happening within cardiology or interesting science. But it's not just reporting, but it's also taking people's opinions about this. How do they interpret it? What implications does this have on practice? And so forth. And I used to be a great fan of this website. So when I used to want to find out about latest publications, I used to always go to TCT-MD. I was approached by the current managing editor, Shelley Wood, and Shelley approached me because they were looking for someone who was a clinician that could be their clinical editor, someone that could highlight what are the hot topics in cardiology, perhaps give a slightly different view than a journalist would have in some of the areas, have their finger on the pulse of what's happening in the cath lab, what's happening in cardiology. So that's where I got on board as a senior clinical editor. I have a lot of interests in that. So I do a lot of the interviews for late-breaking clinical trials. I do topical discussions. I think these are really important. So we've done topical discussions around bullying, around harassment, around racism, around burnout. So these are sorts of issues that will affect everybody, affects people in cath labs all over the world. Japan, UK, America, Russia, everywhere. And I think, again, it's a great opportunity because it's globalization of knowledge and being able to interact with people all over the world. I mean, so with TCT MD, we are part of the digital arm of the Cardiovascular Research Foundation. We're separate, we're independent from them, so we have an entire independent editorial policy, so we're not influenced by them. But we have over 100,000 subscribers. And, I think it's great in that we can look at, interesting papers, we can discuss important topics, and we do that, again, for all the meetings. So it's something that really I'm quite passionate about and something that I think, again, globalizes what we do as clinicians.
About special things. Okay?
Yes.
Do you think modern DES are really better than first generation DES, and why?
Yes, so I do think that modern drug-eluting stents are much better than first-generation drug-eluting stents. I often say to people, it's not what I think, it's what the data shows. And of course, we have lots of data now, lots of meta-analyses where have compared first-generation versus more contemporary platforms, again showing much better outcomes, both in terms of risk of mortality, risk of reinfarction, and target lesion failure as well. So I think that's something that's known. I think why they're better, well, I think it's multifactorial. So first and foremost, in terms of the engineering of the platform, platforms nowadays are much more deliverable than they were. They're much thinner than they used to be. So, for example, first generation drug-eluting stents were 120, 150 microns. Now we've got platforms that are sort of 60, 70, 80 microns, and we know that strut thickness is an important determinant of longer-term outcomes of these platforms. We've also got a lot smarter in terms of the polymers that we use. Of course, I mean, you'll probably remember in the European Society of Cardiology, maybe 10, 15 years ago, there was this big discussion around the risk of stent thrombosis. Yeah. And we've really changed in terms of the sorts of polymers that we use, but also the types of drugs that we use on the stents as well. I mean, there's been a big move from different drugs, ataralimos, sirolimus, biolimus, and so forth. I also think that we've had a much better understanding of how to use these platforms. So it's not just a question of having better platforms, but I think we're just using them a lot smarter than we used to do. I mean, I guess, you guys have been in the business a long time, as have I, and, maybe 10, 20 years ago, we would think that if you saw a lesion, you would stent it, and that's going to be the best thing for the patient. We wouldn't think too much about how we stented it. Whereas now we've completely changed. We have a lot more data. We have data from landmark trials, Courage, Ischemia, Orbiter, that have really changed our thinking about the sorts of cases that we do, the sorts of cases that we intervene. We have trials from physiology like Defer Fame that we know that actually there are lesions that we can leave alone. And actually it's probably better that we leave them alone. And we have a lot of trials now looking at how, when we do the PCI, how we should do it well. So Renovate trial, for example, showing that use of intravascular imaging, particularly in complex PCI, is associated with improvements in longer-term outcomes, particularly in relation to mortality in patients. So I think platforms have changed. I think they've evolved. But it's not just the platform. Our thinking has evolved, and how we use these platforms has evolved. And I think that's
this technology, as it exists nowadays still have some long-term negatives for ensure MACE and etc. Different attempts to improve long-term result we already made as abdominal coating, new thing, polymers, cavity drug loadings. Is there still a space for improvements?
Yes, I think there is. So, when you come to meetings, all over the world, there's two areas of discussion that everyone talks about. Number one, platforms that will resolve over time, so bioresorbable platforms.
Yeah.
Of course, we had the whole absorb story. Initially, we showed, or that we saw that there was worse outcomes, particularly in relation to stent thrombosis. More recently, at EuroPCR, Greg Stone presented data around optimally deployed platforms, because a big discussion early on when we were seeing all the absorb data was, well, maybe it's not a problem with the platform, maybe it's a problem with the operator or how we're using the platform. So then in the later absorb trials, there was certain criteria, a lot more intravascular imaging, a lot more discussion about what you could do, couldn't do. But again, the longer term outcomes seem to be worse, particularly in the first 3 years. Thereafter, after the first 3 years, the curves are almost superimposable. So in my view, there's going to be a big question mark at 10 years whether actually you have better outcomes with these platforms. I think, to my mind, things like the absorb platform are finished. I can't see a way back for them. But there are other platforms. So, for example, in EuroPCR, another platform was shown where the links between the individual rings were bioresorbable. And so whilst the rings remain, the links resolve. And the idea is that you bring back vessel motility. And the 1 year data in simple lesions was quite favourable. Again, I think this is an interesting proof of concept. I'm excited to see what the long-term outcomes are. I guess a second area that people will often talk about is, well, do we need stents? So it's almost back to the future, isn't it? We started off with balloon angioplasty, we moved to stents, and now we're thinking about, should we go back with drug-coated balloon? Yeah, exactly. And, I think there's a lot of good data for in-stent restenosis. We're using these. But there's a lot of now trials, emerging data, comparing stents with drug-coated balloons for de novo lesions. And I think, over the next 3 to 5 years, we're going to see a lot of interesting data in this space, particularly around long lesions, ACS, complex lesions, small vessels as well. So there's a lot of data that either has been published or is beginning to be collected in large randomized controlled trials. So it wouldn't surprise me in 5-10 years time if we're using a lot less drug-eluting stents, are using drug-coated stents. And of course, the other thing is that our understanding is increasing. So now that we're doing a lot more intravascular imaging, we're finding that many of the lesions that we would treat, we don't need to treat. So, for example, in the past, if someone had an ACS and you saw a slightly hazy lesion, you would fix it. You would put a stent in it.
Yeah.
Whereas now with intravascular imaging, OCT, we know that actually if it's just an erosion and not a plaque rupture, and the patient has a reasonable MLA, then, treating it medically with aggressive antiplatelet therapy actually has reasonable outcomes in the short to medium term, up to about a year. So there's lots of erosion trials, erosion 1, erosion 2, erosion 3, and so forth. And we also know that some people are saying that if, for example, you have a plaque rupture event and you have a good MLA, some people are leaving those sorts of lesions. I personally wouldn't. I would still stent those lesions. But again, I think there's a lot of debate. There's going to be new data in this space. So I think, for me, going forwards, there are a lot of evolutions that are happening in relation to stent platforms.
But I think there's also a lot of evolution in the way we think about how we use these stent platforms that's going to change. I think there were two main issues historically with using plain old balloon angioplasty. So the first thing was restenosis. We know that you cause vessel injury, the response to injury hypothesis. You get intimal hyperplasia, new atherosclerosis, and restenosis. That was the first thing. And the second thing was abrupt vessel shutdown. I guess nowadays with contemporary antithrombotic therapy, with more potent antiplatelet therapy, better understanding of anticoagulants that we use during the PCI procedure, abrupt vessel closure is incredibly rare. Of course, then you have the issue of restenosis. And so I personally don't think there's much of a role for plain balloon angioplasty. I think for drug-coated balloons, absolutely, I think that will be something that we evolve our thinking over time. And certainly now that there are a number of randomized control trials that are comparing stents versus drug-coated balloons, a lot of these trials have looked at in-stent restenosis, but now many more are starting to look at patients with de novo lesions. I think the thought there will be to identify patients where you would get good results in those that have a drug-coated balloon. Because at the moment, we have certain predictors. We say, well, as long as the vessel's not dissected and there's good flow, then leave it. Yes. But I think we need a bit more refinement in our thinking. So perhaps doing studies with intravascular imaging to see in those where you think you've got a great result with a drug-coated balloon, which patients come back a year later with restenosis, and then trying to figure out, okay, is there anything on the intravascular imaging that tells us that this is a high-risk phenotype? And actually, even though it looks good on the angiogram, we know from the intravascular imaging that perhaps these are the cases that don't do so well, and therefore we need a stent. And that's really why I enjoy the field that we're in. I enjoy it because it's very much a dynamic process in that our thinking is always changing. We get new data, we get new technology, and we're using this new data and new technology to change our practice, but also to develop our practice with other ideas that then we can use other technologies to assess our ideas and our thinking. The way I practice PCI now is very different from 5 years ago because our thinking with data has evolved. And it's not just using better stents, but just evolving in ideas around who we should stent, how we should stent, what do we mean by an optimal PCI result. And I think, to my mind, that is going to be the evolution for drug-coated balloons over the next 5 to 10 years. Thank you for joining us. It's been a pleasure to discuss with colleagues. Let's hope that the political situations in Europe change, and hope that we can meet again in meetings. So thank you.
Of course. Thank you. Thank you so much.
Yes.